Okay, let's go, Khwezi.
Okay,
Thank you for coming.
Thank you. Thanks for having me, Dee. So if the topic of my dissertation was engaging physician leaders, and it was a Canadian Health Authority experience. Here in BC, we've essentially broken, in the healthcare system, we've broken up the delivery of services into health authorities. And so I chose the largest health authority we have, and supposedly one of the most, it ended up the one they gave me as a site of which to do the research was the one at which they had thought they had the most engaged physician leaders in the organization. So as the results turned out, there things may not be exactly as they had thought they would be. My committee members were Doctors Metcalf, Piazza, and Southern, and Nancy was the chair. So if we go to the next slide, that'd be great. And the purpose of this was to look at the lived experience from physician leaders of what the health authority can do to more effectively engage them. And I looked at it engaging them on 3 levels. A quick backdrop to this is that starting back in 2008, 2009, the physicians started being surveyed by their provincial health ministry about their level of engagement in terms of bringing about the transformational changes they needed to make in the system. And central to that, of course, are the people who have the sole responsibility by legislation and by also knowledge and ability to, one, diagnose, assess, admit, execute, discharge patients from the healthcare system, and that is the medical profession. What the surveys had shown was repeatedly and continually, the level of engagement within of physicians was going down. We had noted this up north where hours had gone up for a bit, but then it stabilized. And the question was, if we're going to try to make the changes we need in the system and we need to engage the docs, my question is, what's going on? Why aren't we doing that effectively? And there were 3 levels that struck me from the work that I'd done with docs. Was one, typically physicians are not prepared to be leaders. They are trained by profession to be lone wolves. To take responsibility, to look at a situation, go in, make a diagnosis, make an assessment, make a determination, and then execute the care plan. So when they're asked to act as a leader of a group or a leader of team of also wolves who may be alpha wolves themselves, that becomes a bit of a challenge, particularly in that medicine did not prepare them for that role. So one is, what do they need to, in order to be effective in their role as a physician leader in terms of their own self-development? The other one was then, what supports or development do they need in order to be lead others effectively, lead teams? And the last one was, how could they be, further supported, if you will, engaged to lead with other organizational leaders within the healthcare system? So it looked at 3 levels: self, team, and then the more, if you will, systemic lens of the organization. And that's the way I looked at it. Next, please. So the participants of the survey, I ended up getting 11 interviews. I had 12. The last one got canceled 40 hours before the meeting got called to the ICU, and then he was the guy on call, so we couldn't end up doing it. So anyway, we ended up getting 8 males, 3 females, and they represented department heads and division heads and a site medical administrator. Those are the 3 various levels of leaders that exist within this organization. They came from the medical and surgical perspectives, but also included anesthesia, and if you want to include OB-GYN, I don't know why you want to include them as, is it surgical, is it medical? But anyway, it was a broad perspective of various medical disciplines were included in that process. The site itself has only 20 doctors, physician leaders. So this was a good representation, if you will, over 50% of them participating in the survey. Hello, next one, please, if I may. So the research question was, I alluded to, not so articulately, was what individual support preparation do physician leaders need to accomplish what administrators ask of them in their leader roles? Then what skills and resources do physician leaders believe they need in order to lead teams effectively? And then what do physician leaders believe the organization's senior administrative team can do to engage them more effectively as administrative leaders? So I had to, one of the challenges we have within, and I think it's a lot of places, we use language and we use concepts and terms for which we do not get an agreement up front by all those who are affected as to what we mean by this thing, in this particular case, engagement. And the same thing can be when we say people are going to be involved or they're participating or included. There needs to be a discussion up front with the people involved in that initiative so that we're all on the same page, have the same clarity of understanding, and then expectations of deliverables arising from that understanding. So in this survey, I defined engagement in the following manner. It's understood to reflect the degree to which physician leaders feel involved and enthusiastic about the work, know what's expected of them, feel they work in a supportive, healthy, respectful workplace where they're safe to stand up and speak their truth, challenge status quo respectfully, and can use their talents, creativity, and innovation to address the issues that face their work groups. So it's rather long, and I think it's rather broad, but when I showed it to the physicians, it was quite well received. What I was surprised at is when I presented it to the executives, and I'm getting ahead of myself, their response to it was really positive in terms of, this is something we can work on to start looking at how do we in our own respective areas define this thing, and what does that mean, and that might help us with what we do and what's going to be in scope and out of scope for the things that we take on. And I'll get to that about where I'm at with this work at the end of this presentation. So we'll get to the next one, Dee. So the idea was that if you're going to ask people to effect a change, get them to actually create it. I'm not a fan of buy-in. That means you're buying into someone else's idea of what's good for you, as opposed to owning and designing what it is you think is going to work to get what the organization wants from those other people who are involved in that work. So this is to be used by the health authority, particularly at this site, to then meet with their physician leaders to determine, okay, given these results, given this is what we think, how do we now choose to go forward in terms of what will be our strategy for engaging our doctors locally here to achieve, to contribute what our site has to the organization's overall objective. Because it's only one site and there are approximately 13 cities in this health region, I caution them that the findings are specific in terms of the specific recommendations are applicable only to this site. Some of the findings can be generalized in some regard to how do doctors feel, but I would feel much more confident if they allowed this research to be duplicated only using a broader spectrum of regional leaders from the various sites in order to be more able to definitively articulate this is something now that represents the broader organization. So that's the only caveat I wanted to give to them about that, and saying, don't use just this site and think that that represents the feelings of all the doctors at other sites, because these small communities are very, how can I say this politely? Is territorial a nice word? And so something done, it's like in, let's say in the States, something done in New York is not going to fly as representative of what happens in, say, LA or Phoenix or Houston or Chicago, okay? Maybe that's the analogy. Can I get the next slide, please? So three key theories underpinning the research were about culture and the impact it has, not only on the leaders and leading and leadership itself, but also in how people get engaged. We also talked about trust, and that was a biggie that came up. And then this whole notion of what is leading. And I have a personal foible about the word leadership. It's been defined in so many ways. And there are so many theories that to think that is, people have a clear understanding of what you mean by it and what the expectations of the person in that role are, is something that each area needs to really sit down and talk about and say, what do we need when we talk about leader? What are the expectations and what is it they're going to do within that capacity? And then within the context of working, you know, what's the leadership context in which they're going to work, and therefore it affects all of these other items. So those were the three things that I looked at in the research to basically help inform how do these things play in engaging physician leaders in their workplace. Next one. So in the key theories of culture, we talked about Shane and his three levels, etc., and the three subcultures of the operator, the technical, and then I can't remember what the other one was right off the top of my head. The one that really stood out for me, though, that really was relevant for the docs, it was stuff that was done by Mintzberg and Gluberman. And they talked about the four subcultures within the healthcare system, and those were those of the how do I say this word? The executive, and they are the people who are the hospital administrators who have been charged with the fiscal responsibility, the financial viability of the organization. Then you talk about the care people, and they are the allied health professionals who execute the plan that the doctors have come up with. The doctors are in the world of the cure. They come up with what are the answers, the solutions to remedy the ailment that faces them, etc. And then there's the, can't remember the last one of the external stakeholders. It's community, thank you. It's community, so I apologize for that. So when we looked at that lens and looked at how the doctors and the administrators were effectively interacting with the docs, what became very apparent was each medical profession, each healthcare profession is educated within a silo. There is rare, if any, cross-pollination of education and educational experiences or shared projects, etc., between the physicians and any of the health professions. So each comes to the healthcare world with their own sense of mental model of how the healthcare system works, but also of what is the truth. And so you typically have within an organization what we call ghost records. So you may have the patient's health record, but typically, and that's supposed to have everything, but it was not uncommon for other health professions in our experience to have their own records because it was more complete from their lens. So part of the challenge here was getting the doctors to understand, and it came out in their responses between the older docs and the younger docs when I would ask, who are members of your team? And the older docs still saw it in the old way of just their peer physicians, whereas the younger docs saw the broader scope of allied healthcare people, the porters, the cleaning staff, etc., as part of the team that contribute to the well-being and care of the patient. So how you regard people, how you include them when you come up with decisions that are going to affect how things are done on that ward or in that unit or in that program or that clinic, the breadth with which you include people through their changes very much has an impact on one, how effectively you're able to be successful in doing what you want, but also in effectively engaging all of those people. For the physicians, effectiveness means basically being able to, one, do what they think is in the best interest of the patient, not necessarily the organization, but also ensure that people are going to deliver the care and supports for the patients have what they need also to make sure that the desired outcome occurs. The Eiffel Tower culture was really cool because, Trump and Hampton Turner talked about it really is, and this is the problem one of the conclusions they end up coming up with is, for so long, healthcare has been a top-down command control mentality. It is extremely difficult for people to really get out of that mind frame. It's the way they've been trained. It's indoctrinated in the medical education. It's indoctrinated, quite frankly, in our political system. And I won't get into that. We can talk about that a little later. And it'll speak to some of the work I think Gary's doing with bullying now. And there's some thoughts I've had about that and where it comes in and the kind of environment you end up having. These issues that affect this ability to be engaged go well beyond just the immediate team and the organization. It goes to the Ministry of Health, and then within the context they work, the political system from which the healthcare system is actually funded, directed, managed, measured, evaluated, audited. Can I get the next slide, please? So when I talked about trust, the research really looked upon what is the impact of trust in the workplace, what are the ways in which to build trust, how do you maintain it, and the ways in which trust is broken. And there was some interesting findings. We'll get to that a little later on with the findings. Next piece, please. And then in leading, we talked about the need to differentiate leadership. What is the leader? And looking at leader as a role. It's something that one does, and it's not a role in which one is always in. Leader has a certain set of expectations put upon it by the various stakeholders who have a relationship or contractual obligation with the person in that role. Leading are the actions or what the people do within that context. And I also looked at various approaches to leading, whether a situational leader or transformational authentic servant. And a lot of these, I mean, we talked about this with Chuck yesterday, you've got stuff like responsible leadership, you've got emergent leadership, and a lot of them have an incredible amount of overlap. And what differentiates or distinguishes at some point becomes very nuanced. Is that a nice way of saying that? And then leadership itself gets to be the context. And then that one, I was talking more about what is the state and the condition of one who guides others on that journey, but also what is the state and condition of the environment and the stakeholder of the people with whom the leader has to work and engage. So it gets to be this state and condition of being of the various elements with which the leader interacts in executing their leading, if that makes sense to you. I hope it does. The next piece. So the methodology basically I used was, we had one-on-one, this is an overall one, it was the one-on-one interviews with the individuals. And they each had, I'm not sure if I had it on this one, an iterative process where they first got their own feedback from the interviews, and they give me permission to basically record them so that I could make sure I got it accurately and also to get the spirit of an intent of what they wanted. So what happened was, once the interview was done, I had made notes quickly. Then I sent it off to a transcription service who then sent it back to me. I then sent that back to the individual physicians to say, look, this was your interview. I need you to review it and tell me if we missed things or they were captured accurately and inaccurately, so that you are comfortable that your story and your perspective has been accurately captured. Once they had done that, I then merged all of them together into this nice little document. And then it got sent back to all of them as a summary of, here's all the items that you guys have spoken with, or you guys and girls have shared. Here are the general themes. Here are the comments. Here are the suggestions you've made, etc. Take a look at them and please provide feedback as to further things you may want to add to or enhance in that feedback. And then finally, after I got that, you went through an iterative process of going through the data. God, I don't know how many times I went through it, but anyway, distilled it to what were the themes and what were the major points they wanted to get across in terms of, these are the things that we think if you address at these levels will help us answer the questions that you asked at these three levels: leading self, leading others, and leading within the organization. That was basically the process through which I went through in terms of making sense of the data that they sent back to me. Next slide, please. So I guess I talked the first stage, second stage, third stage, and the fourth stage. So that was basically how I walked through the process there. Now, what was interesting was we excluded the site medical director of the site from the research. And that was a decision that was made, one, by his unavailability, because there was a chance after the research was done, he came back, said, I can put in my feedback. And we talked with the sponsor, said it actually makes sense if he was to get this just as from his people, and his input is not influencing what his team is saying they need. And that ended up being actually, I think, something smart, so that he could not have, it couldn't come back to saying, it was influenced by him. He's now being given feedback from his people, which he now receives and has an opportunity to take up with the other executive to say, what do we choose to do with this? And then I can then go back with my people to say, what is going to be doable within what you've recommended with the organization, and what will not be doable? What is the context time frame, and how do we then sort ourselves going forward to make that happen? So that was an interesting dynamic, because we also had a dynamic where he thought he wanted to be more involved in the research, and then he had to back out because of other obligations. That whole piece with him, we talk about some of the challenges during the dissertation process. I first tried to reach out to him in April. Okay, by the time that we got to the point of him not being included and just basically going to receive it and going through these various iterations, that was end of November. So that caused a bit of its delays, because there was a piece he had to sign off on to give me permission to speak to his people and to speak to his people during work hours. So there were some things that in the process, they're simply out of your control, and you try to politely encourage them to expedite that, the thought process, their decision making. And but that was one of the personal challenges I had in the process, is how much time was lost with dealing with the physician world. And the challenge was, he's also the ICU intensivist, and he does on-call rotation once every 3 weeks. And during that time, he takes no calls. He's not available. And when he catches up, he takes time to catch up with the administrator on the following Thursday of when he comes back. So it created interesting lags in time. And it was a frustration I kept to myself up till this time. The next slide, please. So what some of the findings were that the identified elements for a shared sense of purpose between physician and engagement were, they thought that the factors that they needed to address within the organization were the culture and the climate. And I just want to say that climate is regarded as one's experience of an organization, i.e., do I see it as a cold, friendly, receptive place that's open for hearing, or is it something that simply, tells me command control doesn't really include me, etc.? It's one's sense or one's experience of what the culture is. Then they talked about leadership, and that was at a personal level, group, and then organizationally. Then talked about the issues with trust, and trust was a major issue. And where that came up as to how big a deal it was when I asked the doctors, what's the trust like in this organization? And at least 3 of them said flat out, you don't want to ask that question. That's a dangerous question to ask, etc. And I thought, wow. And I just said, well, that's nice. I'm here to learn. So the question's going to be asked. And we got to it. And it's interesting about how people perceive trust, and how they perceive trust is either breached or broken. And we can get to that, because there's elements of addressing that come to what are people's role, and what do they see as their responsibility about the thing that they complain about. So in doing this, it occurred to me that engagement is really like this thing, this system, if you will, that has all these elements that make it occur. It's like the parts of a car, you can talk about engagement, but if you don't have these certain elements of it, it really isn't going to function in the way it ought to be. And those, in this case, these 4 elements they defined were just some of the interdependent variables that need to be addressed in order to get this thing called engagement occurring in an effective and meaningful way for the physicians. The other thing was that engagement shouldn't be seen as a thing to do, that it is another project, it is something else that's added by the organization to the workload of the staff. It actually needs to be regarded as a way of being, an ongoing commitment to how one experiences working with others who come to them at that time of need, or work within the organization to fulfill its obligations to the ministry and to the communities they serve. So, and I think this is something that we haven't really looked at in terms of, it's not a thing to do. It is actually a way of being. It is a way of interacting. So that was one of the takeaways for me. Can we go to the next slide? So the conclusions were that the physicians perceive there is a lack of a shared purpose between what the organization wants to do and what they want to do. And I should have really addressed this earlier on. A precursor to the actual interview questions were some warm-up questions, which were, start about, why did you enter the medical profession? What were your aspirations? And how have you fulfilled them? Okay? And that was to just really break the ice, get them feel comfortable, etc. And what happened with that was, at least 4 physician leaders who had said coming into the meeting to their staff, well, this shouldn't take long, I hope it goes quickly, etc. After those first 2 questions, they sat back and said, whoa, picked up the phone or their cells and sent messages, text messages or phone calls to their staff, said, I'm going to be in here a little while. Let's push back the appointments a little later on in the day. So they got to see that this wasn't just, it looked to them like the regular administrative exercise. It was about really listening to and hearing their stories. And their sense of why they came in, the ability to share their knowledge, their creativity and innovation to solve the problems that come to them and make a contribution to their community through their hospitals, they felt they were being challenged in their ability to do that in the way they thought they could. And some of the examples they gave were really good illustrations of legitimate, from their lens, things of that got in the way of them being as engaged as they could be. So part of commitment is one, part of conclusion is one, rethink engagement as a commitment to a being something to do. Another one was, there's a lack of clarity in healthcare as to the roles that physicians are being asked to do, what the expectations were and what supports they would be. When I asked them, what is your role? What are the expectations of you in this role? There was only one doctor out of the whole lot who was able to describe what their role was relative to expectations of themselves, to their team, and to the organizational objective. That was it. And that struck me. And I said, this is in part where some of the challenge lies. There is some lack, there is an ambiguity as to what's expected of me. And the last one is that the physicians are not disengaged. They've simply withdrawn from the administrative efforts because they don't see the connection with what they're being asked to do with their relevance to patient care. They see it more as a lot of the initiatives have to do about ways in which to cut money, to watch resources, and to not necessarily deliver the care in the way they felt was best, as opposed to what was the minimally effective to the organization. So they saw a schism between what they were looking at and what the organization was looking at. And that was interesting. Next slide, please. So the idea was they need to come up with an agreement. Now, some might have talked about it being a social compact or physician leader compact, and we'd use a variation of this with the designing a leadership development collaborative for the entire province. Well, we had to come up with an agreement of understanding. And this one was, we need something that's going to be the framework in which that guides how we get the work done. And so we need to establish clarity and consistency and agreement around expectations of the functional purpose of the physician leader role. What are the performance metrics? What are behaviorally illustrate the values that we are sharing and the ways to address it when we get variances to any of these aspects. And then how they would basically come up with this plan is to have a facilitated process by which they, as physician leaders, with the administrative corporate leaders and the site administrators, come together and say, okay, this will be the agreement we have around how we will effectively undertake, meaningfully engage in our physician leaders, so at this site, we have the desired outcomes and results we want. And that was basically going to be the framework for that. Can we get to the next one, please? So what then happened, and we won't go through all of this, was the recommendations were broken up into two parts. One had to do with what the physician leaders can do, and the other was what the administrative leaders can do. And it was around leadership, it's around culture and climate, around communication, and around trust. And they were basically the recommendations that went forward to the executive leaders. So that was basically the research that was done. What happened with that is I have then since presented to the executive of the organization, the host organization, Fraser Health, and they have taken it on board, and they're now trying to sort out who's got the money to pay this guy to come in and help us, and who's going to do where and where do we start. The folks that I did it with this site, we've scheduled a meeting for October 3rd to actually meet with all the physician leaders at that site to actually start this work of what is the framework, what will be the elements they want to address, and how do we go forward with that. I've since made presentations to another health authority last week to their executives, and they are now asking me to fly up to Kelowna, and that will be sometime towards the end of this month, to meet with their entire medical executive. And then on Wednesday, I'm meeting with another health authority from the north to present to their leadership. The sponsor is also organizing for me to speak with a combination of the Ministry of Health, Doctors of BC, and all the health authorities in this provincial committee to present the work. They had already had me present to a smaller faction that worked with the host health authority, and that's when they said, we need to take this to the provincial body. So I'm waiting to hear about that work and what happens with it. And then that so far is what's going on. I think I'm forgetting something else about what's going on with it. But this morning I got good news. Royal Roads University called back and said they're interested in having me be a second reader for first working with dissertation students. And if that goes well and they like what I've got to say and I can get along with people, then I can at some point hopefully maybe have my own students, but it's also a way to get into becoming part of the faculty with that university. And there's another one that I'm also talking to up north about how to help them come up with a leadership, it's crazy, leadership course for their MBA program, because they don't have it within their MBA, which I found absolutely fascinating. But that was basically the gist of the research. Dee, if you go to the very last slide, because I think there's quite a few here with the recommendations. Is that the last slide? Okay, I guess it was. Go back one then, please. Okay, it's not in this one. Okay, so, okay, thank you. I didn't, the last slide that's not in this one, but it's in the one that I presented to the health authorities, actually speaks about, you know, a way in which is a pathway possibly for this organization to go forward and that they're going to discuss. So I'm sorry I didn't have the right PowerPoint to show that piece, but that's where it is. That's all I got to say. Any questions? I think I speak quickly.
So who has a question for Khwezi?
I do.
I assumed you did.
I was writing it down while you were talking. So Khwezi, I'm really interested in the whole trust piece, because it plays into what I'm doing as well. So I'm curious if you discovered anything or had any thoughts or sort of findings around how trust is repaired once it's been broken.
Yeah, there was quite a few pieces that one had to do with intent, right? Was it intentional? Was it malicious, or was it happened by accident? 2, was it something that had happened, one, as a one-off, or is this a pattern? Okay, something that had been repeated. 3, they found that 1, taking ownership of what happened is very important. Okay, taking, accepting responsibility, and not with qualifiers, just unequivocally, I own it. But what they found that the apology didn't matter if the intent was not well regarded. So if they thought that it was malicious or someone was undermining, it doesn't matter if you apologize. It doesn't matter you do your mea culpa, that, and I'm going to do. That was where the issue of trust was really going to be difficult to bridge. Okay? If it happened by accident and people understand things happen, people move quickly, other things come in, you get distracted, etc. They get that. And part of that was, and we talked about this, was how it gets down to, how do you hold the other people? Do you hold them with positive intent? That is, I know Marty and Khwezi and Riza, Monica are working towards the same objective. So when something goes wrong, if we're really holding each other to our nobler selves, it gets to be curiosity takes over. What happened? What got in the way of, you know, Risa, Khwezi, Marty, Monica being able to do what they said they're going to do? How do I then ask them the questions as to what got in the way, but also in now resolving this, saying, how do I help you live up to your nobler self? What am I going to do standing shoulder to shoulder with you to help you hold yourself to that bigger picture of yourself, okay? Whereas if I didn't hold them with positive intent and truly believe they're working with me towards the same objective, then I held in doubt their intent. And therefore I held in doubt what they're saying to me, because you haven't shown me, you know, that you're in this with me. Does that make sense? So part of this though, and I pointed out to people, is it's incumbent upon all parties to actually get curious first before we get accusing. If we don't get curious, it's easy to go to the judging and to the accusatory and to go down that lousy path. It's better first to ask, what happened? What got in the way? How do we mitigate? How can we help? What can we do? And that leads the conversation a whole entirely different area. And the thing that popped up with a lot of the docs was this whole notion of, do I hold them with positive intent? Do I trust them? And part of that is affected by also the historical experience of working with those people, right? So it's not the first time they've worked with them, etc., right? So it's, you know, the past has affected the future. And one thing which struck me was, when I asked the question with a couple of them, are you aware that what happens here in this interaction actually sets up the basis for your next interaction? So have you checked off, particularly when you're in this contentious experience of conflict, if you will, that we're clear and understanding and we're good, because the next time we come together, we can move forward from this point forward, as opposed to revisiting some unresolved wound that hasn't totally been healed. Does that make sense?
Yeah, it does. So,
yeah, trust was a big issue. And one doctor said it really well. You know, he said it really well. He said, I'm not sure I'd say I don't trust them. Let's just say I'm skeptical. Because we've had enough times where they undertake an attempt to go and do this stuff. And they do include us. They do want to have, you know, engage us in the things that are happening. And then as we go about effecting the decisions and putting them in place, all of a sudden an edict or a fiat comes in from the ministry to the health authority saying, we need this and this by this time frame. And then all of a sudden, boom, all that time and effort that's being spent to work about including others goes out the door, because they're trying to meet an externally exposed deadline by their paymaster. And so what they didn't take the time to do was go back and explain, here's what happened. Here's why we couldn't do this. These guys came in, had this demand, and this forced us to make the decision within this time, which forced us to breach what we had committed to do. And the doc said, if they just come back and explain that to us, then it changes the context with which we see what happened. And it changes the narrative we then have of this place and what we then repeat to our peers. So, yeah, trust was big though, yeah.
So Khwezi, can you talk to withdrawn but not disengaged?
Yeah.
Because when I think about myself becoming withdrawn from whatever situation, I'm pretty much disengaged.
Okay, so they're saying they're not disengaged from the practice of rendering quality patient care. They're not disengaged from working with their other healthcare professions to doing the best that they can in support of patient care. What they're disengaged from is participating in the administrative exercises that supposedly want to help patient care, but they're seeing it's not including themselves or their peers or the people who actually render that service. So they've disengaged from the administrative driven functions, not the care driven functions. Does that make sense?
Yeah, it does make sense. But do you not think that that also impacts their level of engagement with their patients or their peers?
Not necessarily, because there was a good example. One fellow gave, actually, Bert gave the second one. What was interesting was they said, look, I spend a lot of time where I have to be away from my family. You know, I miss family dinners, I miss a pile of stuff, I miss my kids going to that, whatever, because I'm staying late to get something done. I'm not willing, though, to give up that additional time to go to have administrative meetings over dinner, etc. Said that's not worth my time. So the functions that are on the business side of it, they're not seen as adversely they're participating on those things as adversely affecting their ability to deal with their patients or with the people who are involved in delivering that care. Dealing with the administrative folks is a different reality for them than dealing with the care and curing cultures, okay? So dealing with the control culture of the administrators, okay, does not affect the care and the cure cultures in doing their work in their eyes.
Okay.
So
I think that could be a bigger study. Because my experience is the impact of the structure, the administrative piece of it, is impacting their ability to engage with the patients. At least that's my experience here.
Now they see this. I hear exactly. I think I hear what you're saying is, and my experience of being the admin director of medical services with physicians was the stuff they did with me and the stuff they did on behalf of, say, the administrative functions of the medical advisory committee or the medical staff association, etc., or the subcommittees therein, was distinctly different from the work they did in actually rendering direct patient care. Mm-hmm. Okay, one they could see could have an influence on the other, but that didn't affect their passion and the commitment they had to actually delivering the care. They were frustrated by the system in terms of how do I access this stuff, and it's having an impact. So a good example was this. There was an assessment room where they have a bed, and occasionally have to, with some regular use it. Now, typically the bed was sitting up high, and they couldn't use the controls to bring it down, elevate, etc. So you had to have patients fall off, and they'd have to help them up and say, look, this is silly. This is patient care. Give us a bed that actually works. Let's get this fixed. That frustration in being able to find out where do I get the money to get a bed or how do I get that bed replaced is a function of the administrative bureaucracy of give me the resources I need. They're dealing with the patient in that room with their care and rendering how they're going. That didn't change their ability to do that effectively. You know what I mean? So their interaction with the patient is something distinctly different from the conditions in which that care was rendered. So that room is lousy. It's not set up correctly. It doesn't have the right equipment, but I'll do the best I can working with them, with my knowledge, to take care of the actual clinical condition. But the reality in which I'm working, that really is frustrating me. And the fact that they've not been able to replace this, I've been screaming about it for the last 4 or 5 years, and I can't get any action on it. I then turned around and said, let me ask you something. I thought you said you're the medical director of this program and you're working in tandem with the administrative director. They said, I am. I said, Well, do you not see the budgets? Do you not get to direct where the resources are? Do you know that there's a contingency budget for things of this nature? And he goes, I know none of that stuff. I'm not included in those discussions. So they say, we'll work in tandem with the doctors, but they're not including them in the things that affect the resources, replacement and keeping them up to date, et cetera. And no wonder the doctors are frustrated with the administrative arm of it. They're not frustrated, they're frustrated in their ability to as well as they want to, but their ability to deal with their patients and with the nurses and with the allied health, the social workers, the dietitians, that's professional. So there is a distinction between the two. It's not one or the other, but this has an impact easily. The control side has an impact on how well that work gets done. Does that make sense?
The focus of your research too was administrative.
I beg your pardon?
Your focus of your research too was administrative.
Yeah, and that was where, if you look at the recommendations we talked about each of these areas they talked about, recommendations that they had made. A lot of that with them came into communication and in trust with what the physician leaders thought that the organization leaders needed to address, okay? And those were the things that came and affected what needs to happen, okay, as far as affecting the environment in which we execute the work we're being asked to do.
Okay. I think we need to move on because Gary just showed his face, which means he has a question. And if anybody else has questions, put it in the chat box so we don't miss anything, okay? Gary, am I correct?
Yes, thanks, Deanna. Okay. So, Khwezi, you're talking through a bunch of this stuff, but clarify and help me remember as well. The context in which these physicians really understood the concept of leadership. So they were first and foremost practicing physicians, right? And then there was this administrative function into which some of the physicians in different ways got caught up in the administrative roles. But I think that to some degree they equated the administrative stuff with whatever they thought of as being leadership.
Yeah, go ahead.
Sorry, and so it was not first and foremost the way they thought of their roles. It was like this extra thing that needed to be done, which is where they got to, okay, well, if I've got to go to an administrative meeting, that's more on top of me. That's really not a part of what I do.
Right.
And you've got all that mixed, plus the overlay, if I remember right, of this being a unionized environment, which had a lot to do with the way the relationships tended to function.
Right.
If you could just speak to a bit of that.
Yeah, so you're right, Gary. So part of that and what you're talking about was the physician said, first and foremost, they will always come from the cure lens when they address issues, and that if there comes to be a competition between the priorities of the control, i.e. the administrative requirements of the organization, and the cure, which is the actual clinical care, they will always, okay, defer to the cure. The administrative was secondary. They identified first and foremost as clinicians, not as administrative leaders. Right. That was a secondary role, a secondary part to their identity. Okay? So yes, you're absolutely right. And their perception of what they regarded as leader is something that they all spoke of. Now, those who are more clear on what their roles were or what their expectations were had typically gone through a leader development program that is offered through one of the local universities, is also through the leader program development within the organization. Those who hadn't had a much more challenging experience of what the dickens am I supposed to do? So one of the interesting pieces was hearing her saying, I've been in this for basically 3 years and I'm beginning to figure out what's expected of me. And my question was, what do you mean by that? And so we had a very interesting conversation. I said, well, when the next fiscal year starts, what do you understand is your role within the budgeting process, which affects the capacity to deliver services in terms of the amount of money you're going to have to, let's say, do X number of hip replacements or knee replacements, et cetera, and determining the resources around that, but also thereafter in the follow-up care, whether in the community or within the acute system before they're out totally. What's your role in that? And they said, well, they're not including us in that. And I'm going, so how are you acting as a partner to your administrative counterpart? And they said, well, there's a power imbalance. We're not included. We're not. And so there's that sense of powerlessness. And part of their disengagement, Dee, emanates from that sense of powerlessness to affect, okay, the decisions, but they work with the resources to do the best they can. So they're engaged in delivering the care, but they're disengaging with that processes by which they're supposed to be included, but are actually excluded.
And I'm
addressing the questions you had, Gary?
Yeah, no, that's good, because I want to leave some room for other people to.
Okay.
And I'm wondering if, because you have a national health system, if that's a different take than us with a payment-driven system.
Okay.
And I'm wondering if there's, and you don't have to answer that. I just want to throw that out because we've got a couple people in the queue. Lynn Harrison, you want to answer your question or ask your questions? Looks like Todd's just showed his face, so it means he has a question. Anyway, but Lynn?
Okay, thanks, Deanna. Khwezi, fantastic presentation, fascinating. Such a complex system these folks are working in. I had a couple of different questions. One was just, I was curious about the ages of the physicians you interviewed, because it sounded like the younger ones brought a different perspective than the older physicians. And then my other question was around the rewards for leading and making time available for that kind of thing, given how pressured they are.
Okay, so the age ranges, you had people who were basically about to step down and hand the baton off to younger doctors, okay? The comment that was scary, quite frankly, from a couple of the senior doctors had to do with the expectations that the younger generation had in terms of work-life balance. And theirs were, what scares them is the priority they have on work-life balance as opposed to the adverse impact it's going to have on rendering their services within that context. And what they were saying is, when we got trained and came into medicine, we had an expectation that we would have long days, okay? And if we shorten our days, that's all well and good. That means we need more doctors. Because if we're now going to work, 8 hours instead of putting in our 10 hours or 11, that means we see less patients or fewer patients or less work gets done, etc. So where are you going to make up that difference? And that was the concern some of the older doctors had. The older doctors also, as I said earlier on, had a very narrow view of who was in their team. And they looked at their peers, medical staff as their team, whereas the younger folks saw the bigger group of who's all involved in the rendering and the functioning of this clinic or this department or this program, and saw them as the team members. So that was the difference between the older and the younger. As it gets to the reward system, that is something that I think very, very few places in which I have worked do that well. So when you do change management, and let's say use the ProSci methodology, you've got awareness, desire, knowledge, ability, and aptitude, and then reward recognition. Very few organizations actually change the reward system to the desired outcomes. They still have it in the old reward system. They haven't actually switched what they reward to the desired outcome. So the doctors had the frustration is, how am I going to be paid in order to do this work? What you're asking me to do is, and then this was the comment, they said, they're basically giving me $100,000 to do this, and they think that they're buying half my time. Is that a joke? I earn $400,000, etc. This buys only this fraction of my time, and if you want to get more of my time, you need to pay at this. And I said, well, that's an interesting point, but what you're doing is you then are disrupting the pay scale on the administrative side. And you're not really being paid for any of skills or expertise you have in that regard. You are talking about the opportunity cost to your clinical work. So what suggestions do you have? How you reconcile that? Because how are you going to manage that disruption on this side, recognizing that when you come to this area, by your own words, you're a neophyte. You don't know the concepts, the languages, the processes, or how to work with teams, etc. So you're asking to be paid much higher than for work within this realm in lieu of the cost on the curative side. And that's something that the organizations are going to have to address. But to me, and I pointed out to them, and we had that in the paper, was when we explored that a little bit more, it was really a proxy issue. And that was, if they said, if we actually could influence the decisions of what actually happens, then that's not a big a deal. And it's just that you've got to pay a price for frustrating me, you know, for taking away this time I've got from my family to do things. And now I lose capital with my peers because I'm not able to deliver. So I lose some of my credibility. So this becomes to me a proxy for other things that would be addressed if they were more actually meaningfully engaged in the decision-making and decision-making processes. That's just a hypothesis on my part. And it's something I want to pursue with them as we go forward.
Yeah, fascinating. Thank you.
Todd?
Yeah, so I guess my question's kind of multifaceted. So I hear you speaking about a power imbalance in the system. But with the power imbalance, it seems that as the physicians, clinically, they hold all the power. So another thing I guess I heard was you mentioned the hierarchy as being part of potentially the problem, you know, in the system. So what are your thoughts about the fact, I mean, when I look at healthcare, I think of it as three loosely coupled systems kind of thrown together. You know, you've got the physicians, they kind of do their things. And some of the things you just mentioned in terms of teamwork and thinking about finances and payment, they do that for themselves within the context of their system, and they're making arguments related to that. On the other side, we've got the administrators. They're trying to look out for the facilities and the hospitals. Then we usually have the nursing as well. And those three really have to function together. What's your thought? So my question is, do you feel like there's a shared vision? And I know people don't like to use this word hierarchy, but do you think there's the appropriate requisite hierarchy, right, for the aggregate of those three loosely coupled systems?
Okay, so I actually think there's four systems. One is the cure, which is the doctors, which is distinct from the nurses, which is the care. Okay, the control are the administrators, executives, and the community are all the external stakeholders in the ministry paymasters. So there's four actual cultures or four worlds or systems, if you will, within this overall system that's called healthcare. Okay.
Right. Okay.
So that's one thing. So what we have to understand is here in Canada, at least, okay, we don't legitimately recognize. You've got a lawsuit going on with Dr. Day and others about being able to bill outside the provincially funded system, okay? So everybody's fully funded within the system. So the docs don't have to earn the money in terms of you're gonna go out there, chase the patients and get the money and all that requisite to get it. That's already, so the fee schedule is already established. And the fee schedule is actually established in negotiations between the ministry and the doctors of BC. So, and they have within the doctors of BC their own, you know, specialties. Decide for each procedure, this is what we're all going to get paid. So that really is not much of an issue in that with these guys. That's not the issue. The financial part of it is for them is their cost imperative in terms of you want to give up, you want to take time away from my clinical, which pays me this, to do this at the administrative, which pays me at this level. That's where that disparity comes in.
Right.
The power differential is real in terms of those who control the resources dictate what services are rendered, the quantity of those services rendered, and the quality of those. If you're not including the doctors in those conversations, and then they just basically are seen as, quite frankly, just service providers with no input, it's hard for the system then to say, here are the changes we want to make to either one of our systems, programs, processes, etc., because these are the guys and girls who determine, one, the conditions under which a patient can be admitted into the organization. 2, the services that are rendered to diagnose and assess what is done. 3, what will be the care program that's rendered and delivered. And 4, when that patient disengages from the inpatient system of the hospital to go and engage with the community services. So to not engage the people who direct so much of your costs and so much of the actions, I personally am finding myself challenged as to why you would even do that. It's so counterintuitive.
Right.
Does that make sense?
Well, it does. I guess I just wonder why the engagement doesn't work the other direction as well. Because, in the States, what I see is that the physicians quite often don't engage or work with the administration in terms of, controlling costs and, here payment structures. So there's a complete lack of communication between the two. And I think a big part of the trust issue sometimes appears to be the fact that there's no clarity of the requisite hierarchy that exists. So everyone's doing their own thing to some extent.
Todd, bingo. I think that goes back to a point I said earlier on. This is part of, when I talk about the 4 subcultures, when I raised it with them, I said, are you aware these are the different, they all said, what? Didn't even realize those realities exist. So you don't even know that enterprise exists and that each has a legitimate role, legitimate expectations or legitimate input into what happens. And how do we create the space for that? Well, I'll be honest with you. We keep talking about the desire to be inclusive, collaborative, engaging on the administrative side. But quite frankly, a lot of people were trained and brought up in a system in which we had a top-down control, command and control. I will tell you, thou shalt. So you're asking these people coming from that lens to give up, if you will, or share power in how decisions are made, etc. And I think our societal aspirations to function that way far exceeds our executive ability to actually work in that way. We're not there yet. We talk about it, but in actually working in that way to give up the power to share it and whatnot, it doesn't exist. And a classic example is this. In healthcare, in research, trial and error is embedded as part of finding cures, okay? Trial and error is embedded in also the medical equipment to find out the hip alloys that work best for hip replacements and things of that nature. So trial and error is actually inherent and part of the system, okay? With the research, with the products we have. But when we come to actually executing within the hospital to get things done, we don't want any margins of error. We don't want to understand that, something can happen and how do we learn? People get punished instead of having them and using them as opportunities for learning, right? So here he is all in the system. Trial and error is embedded in what they understand. And all of a sudden here, well, we messed up in this. Oh, boom, you get punished. Well, who the hell wants to work in that? You're going to turtle. And that's what you typically get. So part of that is the executives need to understand they're creating the climate and culture in which they're leaving the space for people to work in. They need to own that. Now the doctors, and that was why there's research was in, and it said, we've been doing this for a while and we failed, okay? We administrators failed. We OD people have failed to get them engaged to the level we want. I said, step out of the way. Find out what the docs want. Let them come up with a program, give them, and hold them accountable for what they came up with. Give them the resources they need to make it happen, but hold them accountable. Let them own it. We need to step back and let them own it and then watch what happens, because what we're doing right now ain't working.
Right.
Sorry, I get a little animated.
No.
Yeah, he's a little passionate, just a little. Leslie, did you have a question? Was there a question in that comment?
Yeah. Hi, Khwezi. It's Leslie. Let's see if I can do video here. Yeah.
Hey.
Hello. Good to see you. Great research. Great to hear you talk about it. I guess the piece that is so interesting to me is that under, the assumption of what collaboration looks like from 2 very different cultures. So you talked about the physician culture being one where you can't even make generalizations from one subspecialty to another. Whereas administration is pretty unified in what they need to address. So my question is, are you starting to develop a vision of what partnership needs to look like between administration and physicians. You spoke about, like, you know, let them own it. However, you know, the administration mindset is very homogenized. It's like, here's what we're doing for the whole enterprise. And physician mindset is very specialty oriented. So what do you see, and how do you see the partnership bridging those two? Does that make sense?
Yep. I think part of the challenge here is with the physicians, and they see themselves as one, a brotherhood, for lack of a better word, or a sisterhood, or a humanhood. But within that humanhood, they see also divisions distinct amongst themselves that differentiate, and it's based upon the work they do. I'm not necessarily of the mindset that all of administration is homogenized in their view and vision of what should happen. So in my research practicum, that was done with what is called a workplace culture committee that had been set up by one of the health authorities, recognizing that the engagement within the organization itself was low. And part of it was we need to integrate the physicians in working with understanding all the other people in the system. So they brought them in to talk about how do we start defining what participation, what involvement, what inclusion looks like from a holistic lens of all these other players who came from the cure, the care, the control environments, okay? And some of them actually included from the stakeholder, i.e. the ministry people involved, to say, what does this mean? How can we redefine for ourselves, working together, what this is? So there's a model there, if you will, for going outside the organization, working with all the four cultures to say, what do we mean when we say engagement? What do we mean when we say inclusion? What do we mean when we say participation? So that when we start working together, we've now got a clarity around what I want, the expectations, two, what do those behaviors look like? And three, when things don't go, as designed, how do we resolve those differences and address them? Okay, so I'm not convinced that we did engagement in the health organization. We have that. There's a physician engagement survey and there's one for the health authorities. Our engagement scores on the administrative side really suck. Okay, so and you would, in the work that we did, we found the managers had an issue with how the executives see things. So yeah, we're being told to do, but we don't necessarily, they don't see, or they don't come down to learn and understand. They're just looking at the numbers, but they don't understand the culture, the environment.
Yeah.
And so there's a piece there where learning and requirement is expected, not only the administrators, but also of the care providers. There's a lot of education that needs to go on with all the parties about, one, understanding this is the overall context we're in. Two, if we're going to work in this way, what does that actually mean? So let's pull together, let's have a conversation about that. And here are the elements that you in this area say are going to be important for you, because we can't have one solution fits all. That's just not going to work. So you have to, within the specific cultural environment you're working with, deal with it then, find out what's going to work here. And then there are some commonalities, but you're going to have to recognize the historical realities that existed. So when I was doing this work, for example, we had organizations that had great trust between the control, the administrators, the cure, the nurses, care providers, and the doctors, okay? Then we had others where there was no trust. So you couldn't approach the two of them in the same way, because the other one, when you're dealing with them coming from a place of one, restoring and repairing trust, which is the basis of relationships. Whereas with another one, you're really talking about building and enhancing, because the trust has already been established and the history of success already there. So their reality and what they're going to do is going to be completely different from this other environment. So to say one solution to deal with this, to me, I simply don't understand it. And I just don't understand why you would not think you would frustrate people when you don't take into account their specific cultural context. I just don't get that. But there are ways to do this, I think. But I'm a big fan of engage the people to find a way that they co-create, which they can then be held accountable for and will be held accountable for, because they understand it, they created it, and they want to see it successful, as opposed to something that's externally dictated and mandated. Maybe I'm simplistic, I don't know.
That's helpful. Quite, I agree with you in so many ways, and then there's that piece of just even how do you get access, because administration has a culture that includes meetings and committees and these structures where this work happens, where and then the frustration when you talked about physicians saying, I never heard, well, you didn't come to the committee meeting, or you didn't like, so I hear what you're saying, and I also think about all the structures that need to be changed so that there's a way that we can communicate together.
You know, it's funny, Leslie, you say that, because what that reminds me is what pops up with work I did with some nurses way back when, and that was someone expressing some frustration. And in change management, they talk about basically you need to communicate something minimum 7 times before it really gets embedded right into the people, and they totally start to, absorb, okay, this is the reality. Well, part of that is, when we communicate, are we communicating with our audiences in a way that resonates with them? Right. So, for example, the younger generation wants social media. Forget this committee. They have no time for that. They can be anywhere and come in for the meeting. And if it's quick, it's clean, it's clear, they're good with it. But if it drags on for like 2-hour meetings, no one wants a part of that, so they walk away. Well, others have structured with, we're going to have standing meetings regularly, 10 minutes, when we start our shifts, 10, 20 minutes at the end of the shift, etc., for the transition, the transfer, etc. So you have to tailor your communication for your audience. But typically in administration, we use a monolithic approach to everything. And I'm going, we're not looking at our audience. We're not looking for what people are telling us. We're still, following this. So a lot of it, to me, still sits with us and others, but you've got to know your audience. You've got to communicate in a way that resonates. To just keep harping the same way and not regarding the other.
Yeah.
I don't know.
That's absolutely.
Hi.
Sorry, Todd?
And we have 10 minutes left, so.
Sorry.
No, I was just going to add. I think that's the case. Exactly what Leslie was saying. How do we figure out those structures? But I think those structures are very different for those two groups of people. The physicians used to looking at something and making a shorter term decision, depending on specialty, about how they're going to treat something. Administration's got to look at something over the really long term in terms of thinking about sustainability of the institution. And those two things can be very different. And like you said, how those two talk to each other can be very different. And what the focus is can be very different because of that difference in terms of again, what the shared vision is. But how do you feel, I guess my last question, I'll shut up. In terms of data, how do you think data plays a role in how these knee-jerk reactions are made to the things you mentioned in terms of taking negative actions towards employees for errors and that sort of thing, not realizing there's variance in the system, a variation in the system?
If I heard you correctly, just repeat the second part, the last part of that, Todd.
Yeah, so when I think of data, I think of, everything has variance in it. So any measure is going to go up and down over time, and it really is a system at work, even at the process level. It tends that both sides, both physicians look at things as a single number, and that's what it is. And sometimes administration does as well, especially when that comes to administrative practices. How do you think that, from what you saw from your research, how does that play a key role in these adverse actions they have against each other and not collaborating sometimes?
Well, I think the information doctors talked about often was in the broader lens of, is this evidence informed? If so, show me the data that proves that we should be doing this differently. What can you tell me that says I should change my practice or we should change the way things are? Okay, that's one piece. The other piece that we have to understand is we're dealing with humans. And humans don't change their behavior well. So as an illustration, I had that personally for a surgery. So anesthesia, before you go in, they don't want you to eat until a certain time before the surgery. But surgeries can be delayed, etc. And I had looked up some research around this topic, and I pointed out, why are you starving a patient for this long before you go and operate when you've got research by the anesthesia okay, college that points out you can actually give patients fluids, you know, with nutrients up until this point. And if you look at the pediatric experience, you actually go up and right until going into the OR. So your margins are smaller with pediatrics than they are with adults, but you're not changing your like practices from 20, 30 years ago. And that was the piece around, you can have research, you can have data, but you're also trying to change human behavior. And that's not so easy. So even though they say, I want the data, I want the information, you can give it to them. You've got to find a way to reach their heart, to move them, to change that behavior. So you can give them all the evidence they want. They won't always change. So they can say it, but the behavior doesn't match that. And that's the piece where we talk about, look, let's be honest about this. If you're going to ask people to make a change, the fundamental, and it's, forgive me for the crassness with which I put this, the fundamental question they're going to ask is, what's in it for me? Okay, I've got a status quo going on that's working for me. If I'm going to change that, why? How am I going to benefit? Why would I want to do this? And if we don't answer that fundamental question, okay, good luck bringing about the change in the manner and the efficiency and the speed you want it. We're humans. We just got to understand that's the way we are, you know? I don't know if that answers your question, Todd, or not, but
yeah. No,
you know?
no, we'll continue this.
Yeah.
Absolutely. That'd be great. Thank you.
There's a lot of good conversations in this one, especially for us in healthcare. Anything else real quick? We've got about 6 minutes. Going once, going twice. Yeah.
Deanne, I had a question for Khwezi. It's just, what out of the research did you find most surprising?
What I found the most surprising was how powerless the physicians felt.
Mm-hmm.
That struck me. I've been working with physicians. My first undergrad was actually focused on the medical staff and the quality of care. Okay, and the issue is medical staff care issues and public trust. And I was stunned at the powerlessness that the physicians articulated. And that shook me, to be honest with you. That sense of helplessness.
Okay. I think Dina has a quick question.
I do. Can you hear me all right?
We can.
Was that can't?
We can hear you.
Okay, good. I don't know how many times I pushed this mute button. Thank you for your presentation and congratulations so much on your future opportunities. I'm excited for you. Knowing Kelowna in particular, I had one question about your future research actually. I wanted to know, do you have any plans on including physician leaders from rural health communities and who support First Nations in Canada?
Yep. So we have the First Nations Health Authority up here. You up here in Canada?
I'm in Renton, Washington, but
okay.
I consider it part of my backyard. I go up often.
Okay. So we have a health authority that's called the First Nations Health Authority. So that's one I would also like to go and talk to. However, the Indigenous populations in BC reside primarily within Northern Health and with Interior Health. So when I go up and meet with those doctors, for example, they will be from those respective communities, etc. Now, what you're also talking about, though, is one specific to rural physicians and their education and inclusion, etc. There is a third party that is part of the Doctors of BC. It's called the Rural Health Physician Initiative. And that's one where the Doctors of BC, working with the ministry and the other medical professionals, to have that lens brought into some of the issues and topics. And I expect that they will be part of that conversation at the provincial table, but two, within the respective Interior Health and the Northern Health authorities, because that's where a majority of and also Vancouver Island has them. It's where those stories would be included in those places. So yes, and quite frankly, I don't think they should be regarded differently in terms of provision of access of healthcare. Some of the issues that the Indigenous populations have, man, they're going to be generational, and they are far more, I think, broad-based than the ones we've got otherwise, where we look at the clinical focus. A lot of the social determinants of health come into play with a lot of the issues that we face with the Indigenous population health indicators. That's at least my experience.
Sure, and from my standpoint, I ask because of a social justice implication for if it's not on the budget, it's not valued. And your comment between the divide between administrative versus physician leaders, it really comes down to that. They don't know how to access the funding that they need. And I'm just curious what kind of isolation or resistance or whatnot that physician leaders of those populations face that can directly impact the health of those communities and disparities that you mentioned.
Yeah.
So I will be following up with you offline if that's all right with you. Topic I'm passionate about.
Yeah, I mean, I'd love to continue this conversation offline, actually, let you know what the research is and where we're going. There is much to do with the Aboriginal population, and it's getting more focused with this Prime Minister, not only, you know, as it pertains to the pipelines and affecting the life and quality life within the communities and the impact that way, but also with the education, with the clean water and all the basic stuffs that in the rest of society we take for granted that are just absolute still challenges in some of these communities. So, and issues of governance, which impact the delivery of services, but also access to services. I mean, that is an incredibly complex space that of which you speak, and there's a lot of work to do there. Absolutely.
And I feel that you could pull some really powerful themes. My assumption is that what pulls down in those areas actually does affect everyone else, like an upside down pyramid, that that you could really find some powerful information from that lens. And I would love to support anything on that level with you and your work moving forward.
Absolutely. We'll have to stay in touch for sure.
Okay, good. Thank you so much.
Yep.
Sounds
Thank you.
good. Sounds good. So Khwezi, thank you for presenting today. I think everybody really enjoyed it. And this will actually be posted on a YouTube video. I'll let everybody know when it is posted. I'm trying to get all the past ones up and loaded, along with any of the references. Todd, you just added a reference that I'll make sure that everybody can get a hold of. So anything else? Thank you.
No, only let me just do a little quick clarity for people. We don't have a national healthcare system in Canada.
Okay.
We have 10 provincial systems and then 3 in the territories. The principles of for guiding them for money funded for the federal government, there are 5 principles, yes, that apply to each, but the provision of healthcare services is actually a provincial prerogative in this country. So we have 10 distinct systems, but because of the principles of portability, comprehensiveness, etc., there is a coverage of people across the country and transfer of, you know, rendering of services no matter where you are. So just want to be clear about what you understand is how the system actually works, okay?
Thank you. Thank you for the clarification. All right, everybody. See you soon, I hope.
Hey, Gary,
Thank you so
we need
much.
to connect about bullying.